Ms. Schmalfeldt, it's nice to see you again, and great that we are working together on the ESMO news. Initiated by patients today, and mamma mia, we can do it together again. That makes me very happy.
Yes, I feel the same way. I am pleased with your interest, and we have indeed both already thought about what might be important for our patients, our women. And we have both compiled this, and I am happy if we can now go through it together. And I would say, let's get started right away.
Yes, and there are exciting results again from the ESMO, especially regarding ovarian cancer, cervix, and cervical cancer. This has been really exciting this year.
Yes, so all entities and the ESMO, one must say, are also gaining absolute importance. It is now just as important as the American Cancer Congress, where major studies are presented, which also influence our clinical practice and everyday life and are extremely important for our patients, which is why I'm excited that we can report on this here and that you can highlight again for the patients what this means now.
Yes, let's start. We discussed primarily about ovarian cancer. That is my focus and yours too, and I'm glad that you can now start with the presentation.
Exactly. Let's start. The patients who have already watched us before know this. We first show briefly a disclaimer and then my conflicts of interest regarding studies, research, and training. And now we can proceed with the presentation. We start with ovarian cancer, first of all, regarding the initial situation, that is the initial diagnosis, and then the further systemic therapy. And we have now heard data from a study that has been ongoing for some time and which was shown for the first time in 2019 with the PARP inhibitor niraparib, and at that time showed that niraparib has an advantage in progression-free survival. And now the overall survival data for this study came out and everyone was very, very eager to see them. We are looking at the situation once more again. So it's about overall survival with the PARP inhibitors niraparib in newly diagnosed advanced ovarian cancer.
May I ask something? Advanced? What is that, and from when is it considered advanced? That is certainly FIGO staging 3 and 4, which the majority of the patients have, when the disease spreads in the entire abdominal cavity. Good, thank you very much.
Exactly, and the study is indeed very relevant for patients in the initial situation. Once they have been operated on, the study has taken effect, meaning surgery followed by the subsequent chemotherapy to which the patients must have responded, which most of them do. And then it was checked whether niraparib still has an advantage, and patients were included. As we now know, there are, in ovarian cancer, 50% of patients who have a defect in gene repair in their tumor. This is the so-called HRD, which stands for homologous recombination deficiency, and there were patients included who had this defect and also patients who did not have the defect. The study design looked like this. There were over 700 patients, all of whom had an operation, and the chemotherapy with carboplatin paclitaxel have responded to it. And then one group was randomly assigned to receive niraparib over 3 years. That is, one group received a tablet and the other group only has follow-up with a placebo. And the endpoint was progression-free survival, and the secondary endpoint, which is what we're talking about, it's overall survival. First, the data on progression-free survival was reviewed again, as it was shown in 2019. And it was observed that the patients, it is depicted on the left with homologous recombination deficiency, thus a clear benefit from the administration of niraparib. A hazard ratio of 0.43 is observed, which means conversely that the recurrence risk is reduced by 57%. You can also see it when you first look at it after 20 months. It shows that in one group, over 50% are without relapse, while in the placebo group, it is under 40%. And even when considering all patients, that is, with homologous recombination deficiency, and without, as shown on the right, still a hazard ratio of 0.62, which means 48%. Reduction of recurrence risk. This has also led to niraparib being used as a PARP inhibitor, approved for all patients who have responded to chemotherapy and do not have received Bevacid. And it is also in our clinical practice to use it regularly. And now the data has indeed been shown, again now after approximately 6.2 years of follow-up, so 5 years later. The initial data was shown in 2019, and now we have 2024. And now after the long follow-up period, it is observed that the curves remain consistent. First, on the left curve, the data for all patients, and here too you can indeed see when looking after 60 months. So 5 years, 22% without recurrence, 12% in the placebo group. And if you look at the patients with homologous recombination deficiency who overall have better survival. Because they also respond better to chemotherapy, we see 35% here again after 5 years. Specifically with niraparib without disease recurrence and 16% only in the placebo arm. And for the group that does not have this homologous recombination deficiency in the tumor, you can see that initially there was indeed a difference, which was also statistically significant. This is the 0.67. Here the Hesse ratio, but towards the end, the curves converge. Nevertheless, it shows still, as in the initial publication, that the effect for preventing relapse through niraparib is definitely present and is a real advantage, especially now in the long-term follow-up. No more side effects have occurred whatsoever. And now, honestly speaking, in any case, absolutely expected when you see these curves running so parallel here, even in the overall population, that this would also be reflected in the survival effect. And unfortunately, that was not the case. This is now the data on overall survival after 5 years indicates 42% versus 44%, which is essentially the same in the study. So much happens in the meantime due to other treatments and therapies. That's how we explain that the effect on overall survival is not visible, which was initially disappointing. But when you look at it, this was a group where all patients had tumor residue after the surgery. They all responded to chemotherapy, but actually a group that indeed has a very serious illness. And when we see there, after approximately 5 years, 40% and 44% respectively survive, which is much better than we knew from studies 10 years ago, that overall is already an effect. And with that, I would like to show the side effects again. The PARP inhibitor causes side effects. As you can see, one must especially pay attention to the blood platelets, that is at the top. Thrombocytopenia needs to be monitored closely, and treatment should be paused if the levels drop. Anemia can also occur, and nausea can be a problem, although not severely pronounced, but also a reason to reduce the PARP inhibitor, because we do a maintenance therapy and quality of life is important there, and it is always important that it is balanced. Also, the fatigue mentioned further down is something we need to address with our patients. We know that the PARP inhibitor can also be effectively dose reduced, and it still works. And fatigue and especially nausea are supposed to be significantly improved with it. Therefore, therapy should be dynamically viewed and always customized.
Is that indeed possible? Making adjustments is always possible after consulting with doctors?
Exactly. The dosage is 200 milligrams of niraparib, which can also be easily reduced by approximately 100 milligrams if side effects are present. Now, this is very variable, and it has been discussed. The study, many have said, if it does not bring a benefit in overall survival, then you can also give something later. My opinion on this is, and many share it, many experts as well say it is so important that after such an intensive first-line treatment, first surgery, chemotherapy, followed by maintenance therapy, any recurrence can be delayed. Specifically, we have now seen after up to 5 years, and in my opinion, this is such a great success, that the PARP inhibitor niraparib, even if we do not see an improvement in overall survival, see, it really absolutely has its justification and should continue as we have been doing so far. Because many patients in the study then from the control arm just also received the PARP inhibitor. It was 44%, so almost half. And also the follow-up therapies, so much is indeed happening, and we can manage many things later on. But I believe for a patient to have been 5 years without a relapse is simply quite very important. And for us as therapists as well, because we share in the joy with the patients, that for me, the indication for niraparib has definitely not changed.
Thank you. Indeed, let's move on to the next topic, which also involves the advanced ovarian cancer stages, niraparib, and an immunotherapy. I'm very interested in what you have to say.
Exactly. So now we actually come to a similar study, the ATHENA study, which we have already seen, as it is essentially the same study as before, only with a different PARP inhibitor, rucaparib, regarding tolerability, is also very good. You have to keep an eye on the liver values above. For that, the platelets are less of an issue. It can be an option when using a PARP inhibitor. Results in certain side effects, then switch to another one. And there we also have seen that rucaparib alone works well versus placebo. And now there were 2 additional arms in this study, specifically involving rucaparib, the PARP inhibitor. In maintenance, a checkpoint inhibitor, nivolumab, is also added. Again, patients with an initial diagnosis of advanced ovarian cancer, stage 3 or 4, that is, it spread in the abdominal cavity, and they also had to undergo another operation and chemotherapy, and they must have also addressed chemotherapy. And here already a study design, again with over 800 patients, newly diagnosed ovarian cancer. They received chemotherapy and surgery, and they responded to it. Besides, just one group received the PARP inhibitor rucaparib and the checkpoint inhibitor nivolumab. And the other group, which received only rucaparib, was also randomly assigned and a placebo instead of the checkpoint inhibitor. And now it should be examined whether the checkpoint inhibitor offered also a significant and further additional extension of progression-free survival. And here we can already see the result. As you can clearly see, it shows that this is not the case. This curve even runs a little under the curve with the PARP inhibitor alone. This is now the analysis for all patients. So then you see that maintenance therapy with rucaparib alone is indeed sufficient. And it is honestly quite reassuring because the checkpoint inhibitor nivolumab has also side effects and is an additional infusion therapy. That means even more stress for our patients. But indeed, the rucaparib alone was just as effective. And now again, they looked at, there might still be a group that could potentially benefit depending on the tumor characteristics. PDL indicates the response to checkpoint inhibitors. But here too, we see all the lines actually point to the monotherapy with rucaparib alone. And we have no point or significance regarding the combinations. Also BRCA independent, HRD independent. So we did not find any subgroup where the combination actually would be better. But we had significantly more side effects in the combination therapy. If a checkpoint inhibitor is added, we have more side effects overall. The side effects, as far as the blood test is concerned, they are relatively similar. It doesn't make much of a difference. That is mainly the PARP inhibitor that does this. But when we look at the immune-related side effects, then significantly more side effects occur. That was mainly, they are hidden behind here. That is an underactive thyroid gland. But we will also go over this again later on, another study. These checkpoint inhibitors can indeed be applied to any organ. Ultimately, to the side effects can occur in the lungs, kidneys, and everywhere, which can become truly dangerous. To sum up, it can be said that the checkpoint inhibitor in the first-line setting for ovarian cancer has not brought any additional benefits, only more side effects. Thus, it is definitely not an option and will not be included in our combination absolutely under any circumstances in our clinical practice.
That's a good thing because side effects are really exhausting for every single patient of every type of cancer. And of course, especially the abdomen, meaning the lower abdomen. That's no fun. Let's move on to the next study, which is a relapse study in combination with an immunotherapy. I am also very curious to hear what you have to report.
Yes. So we are staying with the immunotherapies, but are now in the situation where there is a relapse of the ovarian cancer condition. However, the study had a therapy-free interval of at least 6 months after the last platinum-based chemotherapy. And now they have asked, if we then give another round of chemotherapy along with a checkpoint inhibitor and not combining it with a PARP inhibitor, but with the well-known bevacizumab as angiogenesis inhibitors, can that perhaps bring an advantage? So that's the situation. Relapse and at least 6 months after the last platinum-based chemotherapy. Besides, the patients had to have definitely responded to the next chemotherapy in the relapse. And then they administered the checkpoint inhibitor, this time called atezolizumab, but they are all very similar. Nivolumab, atezolizumab are all very, very similar, plus the angiogenesis inhibitor bevacizumab. And in the control group, only bevacizumab, the angiogenesis inhibitor, was administered alone. The idea behind it was that bevacizumab makes the vessels more permeable and promotes angiogenesis, thereby allowing lymphocytes and immune cells to better penetrate the tumor. And then this checkpoint inhibitor, which indeed needs the T lymphocytes, and so that they can attack the tumor cell again, they can penetrate the tumor better. There is good data from laboratory experiments indicating that this concept can work. Very good. After chemotherapy, patients then continue to receive maintenance therapy. In the group with bevacizumab, that is bevacizumab alone, and in the other group, atezolizumab plus bevacizumab, the endpoint was again progression-free survival and overall survival. We have seen the data on progression-free survival before. There was such a small trend indicated, but not significant. And now we have seen the data on overall survival. There we see that the checkpoint inhibitor brings a slight bit of improvement compared to the bevacizumab, but it was not significant. Even if you think the curves differ indeed 10%, differ by 527% and 17%. However, due to the number of patients, it did not achieve the significance, especially because progression-free survival was not significant enough. And then you simply don't know what the effect of the therapies is that have been administered in the meantime. In this situation, it has to be said that even if it looks so promising, here, if a study was not significant in terms of progression-free survival, then to be honest, overall survival is not significant either, because so much has happened in between that it cannot be attributed to this combination therapy alone.
And there are also side effects.
Exactly. And there are side effects, and thus it must be said, it will not find acceptance. Also, here it was checked again to see if there are patients who might benefit after all. These were follow-up examinations conducted later, where you see patients who had actually only had one chemotherapy before, so now they are experiencing their first relapse. They indeed seem to benefit from the combination, or if therapy-free interval was over 12 months in duration, then there is a significant advantage in this context. And now, I don't have the side effects with me at all, but the side effects are important indeed. One always has to weigh that. There are indeed serious side effects with these checkpoint inhibitors, which means one must say that they will not be used in everyday clinical practice, because it is important that we achieve the progression-free survival extends right from the first therapy, and what comes out in the end we can also achieve with other therapies. For patients, it is important when they undergo a new therapy that it lasts long and persists and has a long-lasting effect. That is what the checkpoint inhibitor has not achieved here.
Yes, and a freedom of therapy, so to speak, in that sense, yes, that's a shame.
That's true. And checkpoint inhibitor really always means monitoring, even after 6 months. Hypothyroidism, immune-related pneumonia, and kidney inflammation can still occur. That's not something to take lightly. This is a therapy that needs to be well monitored.
Yes, these are long-term side effects, so to speak, and one has to explain it well.
So overall, one must say that the checkpoint inhibitors in ovarian cancer so far only currently have the DUO study, where the triple combination was PARP, checkpoint, and bevacizumab, where there was an advantage in one group. We actually still need to wait a bit to have more data regarding the follow-up time, but that was the only combination that really showed an advantage. In all other combinations, the checkpoint inhibitor shows no advantage. So in ovarian cancer, it has no significance. Quite different with cervical cancer and quite different with uterine cancer. It's quite simple compared to other tumors. Yes, that's true. You can see that.
Yes, that's true. But we're still seeing that now. However, we now remain on the subject of ovarian cancer, and this time it is about metastatic ovarian cancer, which means it has spread to other parts of the body, other organs, spread ovarian cancer. What do you have to say to present about this topic?
Exactly, that's what we both agreed on. We want to give a bit of an outlook on where things could go next. And there are simply new substances. These are the so-called antibody-drug conjugates. Here, an active substance coupled to an antibody via a specifically designed linker molecule. And this then directly targets the tumor if it has this property. And then the active substance becomes specifically delivered to the tumor cell. And there are now several substances, some of which are already very successful in breast cancer. And also in ovarian cancer, there is much, much more coming. These are all substances that are hard to pronounce. For example, here is topotamab deruxtecan, which is directed against a property on the tumor cells TROP2. Some of the ovarian cancers have this, and it could be a very good option. Those were data that Anna Augnin presented and was able to show that in patients who had already undergone several therapies, in the group of platinum-sensitive patients, meaning those who had another platinum-based combination treatment, but they had already undergone 2 or 3 lines of treatment before, yet a response rate of 66.7% is a lot. And for the patients who have already had at least 3 prior therapies and just a short therapy break, so less than 6 months, the response was still 35%. And that is quite exciting and could thus be a substance for the future. Let's say it actually does have side effects like chemotherapy. One must monitor them, but that could just be a prospect for the future because we also need substances that we can effectively use after bevacizumab, after PARP inhibitors that actually work well.
And who is responsible of finding out whether I have these receptors, so to speak, or whether I am exactly eligible for this kind of therapy?
Exactly, that needs to be determined in pathology, and there we must now determine several factors, because the further antibody-drug conjugate that we have is the mirvetuximab soravtansine. We already have much, much more data on platinum-resistant relapse, meaning when the relapse occurs less than 6 months after the last platinum-based therapy is behind them, and the patients had all already an average 3 prior therapies, had PARP inhibitors, had bevacizumab, and these substances have shown very good response. And now we have seen data from a study in the platinum-sensitive setting, so a longer therapy-free interval, and there again we have seen response rates of 51%. And as you have very correctly pointed out, indeed, what is truly important is that the patient's characteristic in their tumor, and in this study, it was 44%. Often it is also only 1/3 of the patients, according to our clinical experience, but they have this folate receptor alpha on their tumor cells, and then they are suitable to receive this antibody-drug conjugate. And the mirvetuximab soravtansine is a well-tolerated, mild chemotherapy. I would say you need to apply the eye drops well. It causes side effects on the eyes, but from blood test shows very few side effects, indicating it is very feasible and a good option for patients. And therefore, starting today, in the case of a relapse after 2 lines of chemotherapy, folate receptor alpha and HER2 should actually be consistently and routinely tested in tumor tissue, because we now also have an antibody-drug conjugate for that, which should be used if necessary. And for that, it is important to obtain tumor tissue from the initial or second surgery. There is no need to perform a new biopsy. You can ask the pathology department, who have all picked it up, the tissue, that this folate receptor alpha is determined, or HER2. HER2 is easy to determine. All pathologists can do that. The folate receptor alpha requires special antibodies, but this should now be established. Be established throughout Germany in the next 3 weeks so that it can be determined without any problems. This is a simple immunohistochemistry, doesn't cost much, so it can be done.
And the material, that is the tumor material, is supposed to be stored for about 10 years in the hospital after surgery, so to speak, and that's why it can be tested well even afterwards.
Exactly. So that is our message. There are new options, new substances, which are also well tolerated, and that is why we now have to consider additional tests in tumor tissue in addition to HRD and human genetic counseling in the event of a relapse.
I would like to thank you very much for this beautiful presentation and for your intelligent and scientific explanations. I would like to say goodbye and until next time.
Thank you for the patient-friendly discussion. Thank you.